moving forward, the topic for the next session is liver transplantation for HCC. And I would like to invite the chairpersons, Dr. Subodh Varshney, gastroenterologist surgeon from Bhopal, Dr. D.S. Behrani, senior consultant physician from Jabalpur, Dr. Rahul Agrawal, medical oncologist Bhopal, and Dr. Sachin Gupta, hepatologist and gastroenterologist from Bhopal.
Hello. Next topic is liver transplantation for SCC. Is any stage suitable? And for this talk, I invite Dr. Prashant Bhangui, who is Associate Director, Hepatobiliary and Liver Transplant Surgery at Medanta, the Medicity Hospital, Gurgaon in New Delhi. His clinical research interests include management of patients with liver metastasis and developing the field of transplant oncology and living donor liver transplantation. Dr. Prashant, please.
Thank you very much, sirs. Chairpersons, ladies and gentlemen, I know I'm standing between you and much better things, and probably it's one of the last talks of the day, but I try to be quick. I think we've covered a lot of this in the panel discussion that we had, and I'm going to try to be short and quick with this. So I've been entrusted with a talk on which we can actually have a 2-day conference. You know, which stage of liver transplant is, of HCC is liver transplant can be done in those particular patients. So what I'm going to try to do is address this in the form of when, in whom, and how. It's not that simple to answer this question, and I think the main aim in this case is how can we achieve best outcomes in these patients. Now let me come to 2 facts. Fact number 1 is that in patients who have HCC, death occurs primarily because of 2 reasons. One is because they normally occur in cirrhotic livers, so patients who have decompensation, and that's what we discussed before, and also because of advanced metastatic disease. We know that 90% of HCCs occur in a bad liver, and the underlying CLD most commonly used to be hepatitis C, B, V, and alcohol, but now we have NAFLD and NASH, which is now MAFLD and MASH. The second thing is HCC is a very wide spectrum. So you look at tumors which are a single HCC, less than 2 centimeters size, up to large HCCs with vascular involvement. I'm going to base my talk on these 3 things. Number 1 is this BCLC 2022 update. Number 2 is the INASL 2023 PURI 3 recommendations. And number 3 is this consensus paper that we wrote from the International Liver Transplant Society of India, where I was one of the primary authors, where we looked at where and in whom should we transplant for HCC. So these are the 3 things that I said. Number 1, when. Number 2, in whom. And number 3, how to achieve best outcomes in these patients. Let's come to when. Again, a lot of this has been discussed in the panel discussion. I'm not going to go into details of this. Number 1, very early stage HCC. If you have a candidate who's a potential candidate for transplant, or if you have an early stage HCC, where you have either a single nodule or up to 3 nodules, none more than 3 centimeters in size, that means within Milan criteria, and if you have a portal pressure which is high, you would transplant these patients. So this is very clear that you would transplant patients, and we said the same thing in the INASL classification, in the PURI 3 recommendations. Very early stage and early stage we should transplant. Now, in the early stage, whom would you resect? Again, emphasizing on the fact that if you have an optimal candidate who has a more than 2 centimeter up to 5 centimeter lesion, we can resect these patients if they have no clinically significant portal hypertension. Now, this is something that we published a long time back. This was published in Annals when I was working on this in France. And even in those patients who have early tumor, and that's where I begged to differ with what Manav said, if you look at resection versus transplant in these patients, the best outcome, the best oncological outcome is still given by transplantation. So even if you have a single tumor which is less than 5 centimeters in size in a cirrhotic liver, you compare the results of resection and transplant, the best oncological outcome is transplant. But should we transplant everyone upfront? It's not feasible because of dearth of organs. Everyone cannot afford a liver transplantation, and logistically sometimes it is not possible. So a strategy has been suggested which is called salvage transplant. What does this mean? You resect a patient who is resectable, and if he recurs, then you transplant that patient. So this is the strategy of salvage transplantation. Does this give the same results as upfront primary transplantation? So we tried to address this in this paper. Again, we published this in Annals of Surgery, 2015. And what did we show? If you were to do a primary transplant or an upfront transplant in a patient who has HCC in a cirrhotic liver, look at that 10-year survival, 63%. If you are to do a salvage transplantation, 10-year survival is only 35%. And same with recurrence-free survival and disease-free survival. Why? Because if you resect a patient and then that patient has a recurrence, more often than not, that patient is going to have extra hepatic recurrence. So you will not be able to transplant those patients. So only 35% of patients whom you resect and they recur will actually have a transplant. And that's why the strategy of salvage liver transplantation is not a good strategy. And if you ask me, in the age of transplant oncology, what is the best oncological treatment in a patient who has early stage HCC? The answer is still a liver transplant. In a very early stage HCC or early stage, best outcome. But in those patients who have a very early stage HCC, as we have discussed before, if it is logistically not feasible, if you can go ahead with a resection, then you can do a resection or ablation with outcomes which are inferior to transplant, but can be adequately there if you have a tumor which is less than 3 centimeters in size and you do a resection in those patients or you do an ablation in those patients. These are the only patients where I would suggest that probably you should do a resection or ablation. Otherwise, transplant is the best option in these patients. Now, in whom? So now I come to that next stage, which is called intermediate stage HCC, for which I was saying that before 2022, no one spoke about transplant in these patients. All of them were either given TACE or they were given systemic therapy. And this now has changed. Why is this important? It is important because irrespective of whatever surveillance we do, most of the patients that come to a gastroenterologist, hepatologist or a surgeon are those who have these multifocal or large HCC with portal vein tumor thrombosis. And in them, as I said, TACE or sorafenib was what was prescribed. Now, for the first time, as I said again, we have transplant coming in here. And why is this true? Why should you transplant a patient who has multicentric HCC? And this is the basis for that. That the tumor has come because the liver is bad, and the tumor is going to be multicentric even if you don't see it on radiology, on pathology. And what is the best treatment for any cancer? R0 resection. How will you achieve an R0 resection? You will achieve it by removing that whole tumor, which is the seat of that cancer. And therefore, for multicentric HCC, the best treatment is a liver transplantation if he is within your criteria. These were the conventional criteria, but as we said, there are now expanded criteria both in the DDLT as well as in the LDLT setting. And what has changed now is now you have realized that tumor biology is the king. It's not just number and sizes. You have to look at tumor biology and what we were saying in the panel discussion and what Dr. Manav was stressing. You look at AFP, you look at PIVCA, you look at FDG18 PET avidity, and you decide whether this patient should have a transplant or not. What did we say in this consensus document of the ILTS? That we should look now at composite criteria of tumor biology and response to neoadjuvant or downstaging treatment and decide whether this patient deserves a transplant or he does not deserve a transplant and he's going to get good outcomes. This is just one example. This we published in 2021. This is the largest series in the world today of living donor liver transplantation for patients with HCC. This is our criteria at Medanta, and I'm just going to go to the last slide and show you what we do today. This is a paper which I would exhort you to read. We've looked at how you can use tumor biology to select these particular patients, categorize them into low risk, moderate risk and high risk, and that's the difference in the recurrence rates when you transplant these patients. So what we do today is follow this algorithm. If you have alpha fetoprotein, UCSF, FDG18 PET avidity, based on that, if they are low risk, we go for upfront transplant. If they are moderate risk, we will do downstaging and then transplant them. And if they are high risk, we would only do downstaging and see if we can bring them to low risk and only then transplant these patients. So this is how you incorporate tumor biology into your decision to go ahead with the transplant in these patients. And the second thing that I mentioned to you is that the BCLC 2022 has for the first time talked about something called treatment stage migration. That means you start with TACE in a patient, but if you are able to downstage these patients and bring them into criteria, then you should transplant them. So you're doing a stage migration from palliative treatment to a curative treatment. And this is what is important in BCLC 2022, and a similar thing that we put in our cell criteria as well. Finally, I'm going to go to this portal invasion without extrahepatic spread. Whatever any algorithm says, you're talking about more than 2 years survival there with systemic therapy. The actual median overall survival in these patients with whatever atezobev you use, whatever lenvatinib you use, it is 5 to 19 months. And they will progress in 4 months. There are those very few cases who are going to respond and actually going to give long-term survival, which is almost unheard of. So like we discussed in the panel, the aim in these patients is to use therapy to downstage them, to bring them to a curative treatment, which is, if possible, a transplant. So we are looking at this group of patients, and everyone, when he sees such patients, says that I have nothing to do, because you assume that this is systemic disease. You assume that this disease has already spread when it has invaded the blood vessels. And that's why every guideline says it's a contraindication for any sort of therapy. But again stressing that you cannot put portal vein tumor thrombosis and extrahepatic disease together. They are different patients and you have different therapies which can respond. I'd just like to look at this. Why I'm showing you this picture is this is the classification of portal vein tumor thrombosis in HCC. The reason being that if you have a VP1 or VP2 tumor thrombus, this is something called segmental portal vein thrombosis. And the outcome in these patients is very different from those who have lobar portal vein thrombosis, which is the VP3 or VP4. So if you have a main portal vein tumor thrombus or a right portal vein tumor thrombus, the outcome is different as compared to if you have a tumor thrombus in one of those right anterior, right posterior or the segmental branches. We started working on this way back in 2015. In this paper that we presented, we showed 13 patients who had VP1, VP2 tumor thrombosis. Even if you were to do straight away transplant in these patients, we could get a survival of about 72%. At that time, we had only follow-up of about 3 years. So we could look at 3-year survival, it was 72%. So we could get that survival. After we presented this study, there were 3 other studies that were published from Seoul, which showed that if you have VP1, VP2 and a good tumor biology, alpha fetoprotein less than 100, you can actually go ahead with transplant in these patients, whereas in lobar portal vein tumor thrombosis, you should not transplant them because the outcomes are bad. This was shown even in the DDLT setting, and they showed that if you have lobar PVTT, it's a contraindication, segmental, you can go ahead if you have good alpha fetoprotein. Now you will ask me, are the results same with resection and transplant for tumor thrombosis? And this paper clearly shows you that if it is a segmental portal vein tumor thrombus, a transplant is better than resection. Why is this possible? It is possible because you have got very effective therapies today to treat the portal vein tumor thrombosis if those therapies are used in the correct manner. Everyone asks me, you get these great results with transplanting patients with portal vein tumor thrombosis after doing TARE. We are never able to produce those results. It is because you're not doing your TARE properly. So if these therapies are done properly, you're going to get good results in patients with portal vein tumor thrombosis, even with the use of concurrent chemoradiation. This is one of the largest centers for living donor liver transplantation in the world, Asan Medical Center. They use a combination of TACE along with radiotherapy to downstage patients with portal vein tumor thrombosis. And today we are even talking about immune checkpoint inhibitors. So we thought that it is not good to transplant patients straight away. So let's first downstage these patients with portal vein tumor thrombosis and then transplant them. So what did we use? And we published this in 2021 in Transplantation. Again, this is the largest series of LDLT done in portal vein tumor thrombosis after downstaging. And we showed that with this protocol where we use TARE and SBRT to downstage the patients and then transplant them after downstaging, we could achieve these results. Complete disappearance of FDG18 PET avidity of the tumor thrombus, of the tumor using either SBRT alone or a combination of SBRT and TARE, and we could get these results. You're looking at a 5-year survival of 53% as opposed to a survival of about 3 months or 6 months if you were to do nothing in them. These are our updated results which I presented in ILTS last year. Now it is 57 patients whom we have transplanted, and we are still able to get about 57% survival in these patients, provided that we are able to downstage them, and you see here the benefit in those patients. There are some caveats. Only 50% of them will ultimately reach a transplant. You need to have a CTP-A patient who is going to have a good amount of non-tumoral liver volume. You need an adequate waiting period to test the tumor biology, absolutely essential. And it needs to be done by an expert IR and radiation oncologist if you want to get these results. So in the consensus conference, we said that we should do TARE SBRT, and I hope in Puri 4, we will be able to say that in some of these patients, we can do LDLT as well. Finally, how to achieve good outcomes? 1 more minute. We need to rule out right at the beginning extrahepatic disease, because extrahepatic disease is a completely different scenario. You should not try to do curative treatment. It's not going to be possible in these patients. And we've even gone to the extent of doing EUS FNAC of lymph nodes, which are suspicious, to rule out metastatic disease. The second thing is that after transplant, you need a very stringent follow-up in these patients. So instead of a 6-monthly imaging, you will need a 3-monthly imaging, alpha-fetoprotein PIVKA2 levels. And if you catch the recurrence early, again, this is something that we published recently, if you catch a recurrence early after transplantation, you are able to treat them and still get a long survival if you use multimodality treatment in these patients in order to treat the recurrences. So to conclude, ladies and gentlemen, I think today we are in a day of transplant oncology, the discipline of transplant oncology, where we have to all sit together, the surgeon, hepatologist, oncologist, radiologist, pathologist, intervention radiologist, sits together and decides what is best for an individual patient. We cannot generalize, we need to look at what is best for an individual patient, and I think with this multidisciplinary approach, we can personalize therapy and obtain optimal outcomes. Thank you very much for your patient listening.
Thank you, Dr. Prashant, for giving excellent account of liver transplant. I wanted to know about what is the role of biomarker protein induced by vitamin K absence.
So I think, sir, the issue is that for a long time we were neglecting PIVKA2. There was only the Japanese people who were talking about PIVKA2 as an important marker. In HCC, about 60% of HCCs will express or secrete alpha-fetoprotein, 40% will not. What studies have shown is, if they are non-AFP secretors, almost all of them are PIVKA2 secretors. So today, over the last 2 years, we've changed. We've changed from doing only alpha-fetoprotein to a combination of alpha-fetoprotein and PIVKA2. One of the centers there, the Seoul National University from Seoul, has actually come up with a score which is a combination of alpha-fetoprotein and PIVKA2, and that tells you about the chances of recurrence post HCC. So we should do a PIVKA2 in these patients, especially if they are non-AFP secretors.
And the prognosis in the patient with hepatitis B positive and hepatitis C positive, taking treatment, not taking treatment for the virus.
So I think with the effective hepatitis B and hepatitis C treatment that we have today, to a great extent this has become immaterial. However, hepatitis B virus patients present to you with very large HCCs, and this is something that is known. What is happening today is that hepatitis C infection or hepatitis C requiring transplant is reducing, but hepatitis C with HCC, so now the HCC is showing up in these patients, that is increasing. So I don't think we've looked at this, we've looked at etiology and differences. Usually hepatitis B virus tumors which are presenting as large tumors with vascular invasion, these are the ones which have poor prognosis, mainly because of the size, and we know that size is an indirect marker of bad disease.
What is the cost in your institute?
Cost for liver
Cost
transplant?
of the liver transplant?
21 lakhs. That's been
21
the
lakhs.
package for
And how many you have done so far?
4,500.
4,000 in the
550 of HCC.
HCC 500. Very good.
Excellent talk, Dr. Prashant. I would like to know what are the predictors
Sorry, sir,
of
due to shortage of time, we would like to request you to move forward.
So in the interest of time, we close the session, and thanks everybody. Thanks.
Thank you.